Good afternoon, everyone. My name is Deborah Hodges, and I'm with the Institute of Medicine of Chicago. Thank you today for joining Opioid Use Disorder and Medication-Assisted Recovery. So I am the program manager for IOMC and also the association manager. So today's session addresses the current crisis facing us in Chicago and the nation, and we're very fortunate to have two outstanding speakers with us today, and that are going to share their insights and their expertise with us. And that is Dr. Tom Allen and Dr. Tanya Sorrell. So thank you so much for both of you for being here with us today. So today's topic is a very important one. And as you'll probably notice in the news, there is an abundance of news almost daily in regards to opioids and substance abuse disorders and what needs to be done about it. Just to give you some recent highlights of what we've seen in the news recently is the Chicago Tribune reported on October 28th that substance abuse is on the rise in Chicago. There's also in 2022, Cook County had the highest number of fatal opioid overdoses ever recorded in Cook County at 2,000 deaths, which are up from 2021. And most of these deaths involve the synthetic opioid fentanyl. Of this, we've also looked at some surveys and polls. 26% of Americans say that the greatest threat to the U.S. public health is opioids and fentanyl from an Axios poll that was reported in August 2023. And then the next threat was obesity at 20% and gun violence also at 20%. And the fear of cancer was at 11%. So this is rather remarkable that we have such a fear and threat right now with opioid disorders. So I'll give you a preview of the organization of today's program. We're going to address a few of the upcoming programs very briefly, just so that you have an idea of the other seminars that are coming up from the Institute of Medicine of Chicago. We will conduct a presentation with our speakers today, which will be about 40 minutes or so. And then we'll go into a question and answer period, which will be about 15 minutes, and then closing after that. There's no rush, no one's going anywhere. We're all excited to be here and to hear what our speakers have to say. So the learning objectives today of this program are, you're going to be able to walk away and describe the current opioid overdose environment in Cook County and Greater Illinois. You'll also be able, we hope to acknowledge the current efforts at the local, state, and national level for opioid education, remediation, and treatment engagements for persons who use drugs. And the third objective is identify barriers and facilitators to continued progress in effectively addressing the opioid crisis and obtaining needed outcomes. Our speakers are Dr. Tom Allen. He is an Executive Medical Director, Behavioral Health of Government Programs with Health Services Corporation, and is involved in a 5-state region: Illinois, Montana, New Mexico, Oklahoma, and Texas. And he's also the Blue Cross Blue Shield Illinois Chief Psychiatrist. He is a Billings Fellow with the Institute of Medicine of Chicago and is a director on the Board of Governors. Dr. Tanya Sorrell is a PhD Associate Professor with the Department of Psychiatry and Behavioral Medicine at Rush. And Dr. Allen will share more of Dr. Sorrell's bio shortly with you in a few minutes. If you're first time joining us, let me just share a little bit of information about IOMC. The Institute of Medicine of Chicago is an independent, nonprofit organization of distinguished leaders in the health field who collaborate to improve the health of the public. We draw upon the expertise of our diverse membership, along with other regional leaders and stakeholders, and IOMC addresses critical issues through a range of interdisciplinary approaches, including research, communication of trusted information, and community engagement. We are a 501c3 nonprofit organization, and proud that we can say that this year we're celebrating our 108th anniversary of IOMC. So let me just briefly share with you a couple of upcoming events before we get today's program started. Tomorrow, there'll be a hybrid event at Rosalind Franklin University from 6 to 8 o'clock p.m. It's a symposium on race in America, maternal mortality, a nation in crisis. So feel free to register for that today online on the IOMC website, or you can go to the Rosalind Franklin website. And as I mentioned, it's a hybrid event, so in person or Zoom is both welcome. On November 28th, our webinar, we are proud to have Dr. Georges Benjamin, who is the Executive Director of the American Public Health Association. And he's going to share with us the role of non-governmental organizations in public health and the status of public health funding, infrastructure in 2023 and beyond. So that'll be a 1-hour webinar in November. And most importantly, we want to share with you that we've set the date for our State of Health of Chicago program that's coming up on December 14th. It will be held at the Grand Lux Cafe in Chicago. And that program is from 4 o'clock in the afternoon to 8:30 in the evening. We are proud that we are going to have Dr. Shuker, who is the Senior Vice President and Chief Health Officer with Kaiser Permanente. He's going to be the keynote speaker. And there will also be a panel of speakers who will be speaking to important topics regarding the State of Health of Chicago, Illinois, and our nation. This will be the 9th State of Health of Chicago. If you're not familiar with this particular convening, it will take about an hour and a half, 90 minutes, close to 2 hours of discussions on various topics. This is rather a report card on key issues of what's currently happening and what is most important to address. From this, IOMC does a scan, an environmental scan from everyone's presentations. And with the Board of Governors, they determine what their primary focus is going to be for the next 2 years. So a State of Health of Chicago convening is held every other year. So primarily all of the webinars and most of the events will be focused on those key issues and the impact that IOMC can have on our communities as a whole. So right now, what I'd like to do is to turn the presentation over to Dr. Allen, and he will guide us through the remainder of the session until the very end with Dr. Tanya Sorrell. So Dr. Allen, it's all yours.
Thank you, Deborah. Good afternoon, everybody. Thank you for joining us today. We are delighted to bring this topic to all of you. Dr. Sorrell has an excellent presentation to give. And I just wanted to give you a little bit more information about Dr. Sorrell's background. She has doctoral training in rural and urban underserved mental health and substance use services research, and a minor in complementary and integrative behavioral health practices for Latino groups. She is the director of the Illinois Substance Use Disorder Center of Excellence and is on the Illinois Substance Use Advisory Council, developing similar programs for substance use disorder access, care, and outcomes improvements in Illinois. Her publication record reflects translational research interests in increasing behavioral health care and service utilization using culturally based approaches to improve the overall behavioral health, substance use outcomes of rural and urban underserved populations. She's a licensed and board certified psychiatric nurse practitioner who specializes in child, adolescent, and adult psychiatric medication management. So I will hand this over to Dr. Sorrell. Thank you for being with us today.
Thank you so much, Tom, and as well, Deborah. Thank you for this opportunity to be able to present. We've talked, and Deborah gave us a great opening on the current overdose crisis, and we'll focus. We used to call it the opioid crisis, but opioids have been around for thousands of years. It's actually the overdoses and sadly the subsequent deaths that have really been more alarming in these last several years. And we'll talk about why the pattern may be changing over time than what we initially saw in the first part of this overdose crisis, and how we can look at making a difference heading on out. We recognize that what is an opioid use disorder? It's the problematic pattern of opioid use that causes impairment and distress. And we used to say that if anyone was using a substance, were they potentially misusing it, or sadly what we called abusing it? But we recognize it's that pattern of use that causes the difficulties. Physical cravings, dependence, using despite negative consequences, and particularly related to opioids, negative withdrawal symptoms if attempting to stop using. In 2020, there was an estimate from the CDC that about 2.7 million people ages 12 or older were reported having an opioid use disorder. That's not people who were using or potentially misusing opioids, but actually met the criteria for disorder. They're thinking right now approximately 5 million people in total may have problematic use and may be at risk for use. So this is an ongoing problem as well, as Deborah pointed out earlier. But what may not be known or is known as well is that opioid use disorder can be very well managed and treated. The medications for opioid use disorder, and this, as we know, in medicine, we go through a number of different acronyms, so you have to keep up with the acronyms. The current acronym du jour is MOUD, or medications for opioid use disorder. They're not only safe, they're effective, they decrease those risks for cravings, they prevent the withdrawal symptoms, and particularly with buprenorphine and methadone, if someone uses an opioid on top of it or may have a trigger and relapse to use, it may minimize their risk of overdosing from that additional opioid as it's blocking off that mu receptor in the brain. But there's another area that we recognize that part of this, and why part of this is so important, is the next slide. Not only can opioid use disorder be treated, but it's actually in medicine one of the best treatments for any medical illness. Opioid use treatment, opioid use disorder treatment with methadone or buprenorphine has approximately a 60% or 50% efficacy for continued stability in care, continued recovery in care at 5 years post initiation or induction on the medication. So thinking about that though, we realize that patients with no buprenorphine or methadone use, and that's that top line, the days without using per month are continued higher than either those patients who may be taking buprenorphine or patients that are taking methadone. And to give you a good comparison, the best chronic medical illness that we have data on is hypertension. And last year, the Lancet worldwide reported that the number of patients stabilized on their hypertension medication was 45%. So that's the best that we have in terms of stability for a chronic medical medication that we know that's impacting in a medical disorder that's impacting millions. And methadone and buprenorphine are better than that. So when someone in medicine, and we always want to be able to treat towards recovery or treat towards stability, these are two of the best medications and treatments for a medical disorder that may be currently out there across the chronic medical illnesses that we diagnose. That's important as we continue to discuss this. We know that there are three, or has been what we've said, three waves, so to speak, of the opioid overdose deaths. Now, certainly opioids have been there and been around, as we said, for thousands of years, but we can see that although people have struggled from time immemorial until more recently, the past 20 years have seen the most notable increases in opioid deaths in the US. From 2000 to 2013, you see this first rise, particularly with prescription opioids and overdoses. Then that next rise from 2010 to about 2015 is when we feel, okay, we were aware that prescribed opioid medications might be problematic, might cause dependency and lead to overdose deaths. And so we actually took a training, took steps to look at decreasing the opioid prescription proliferation in our society, but the overdoses increased. And then what we saw for this wave 3 was actually the synthetic opioids that started around 2013. And now, if you see in the purple line, from 2013 to 2021, those significantly increased. And so those synthetic opioids, namely fentanyl, while heroin deaths actually have decreased in the last 5 to 7 years, because the more predominant drug that's in the opioid supply and in the drug supply is now fentanyl, not so much related to heroin. Because of that, you've also seen the funding for opioid use disorder research increasing exponentially during this same time. That last wave, or as they call it, third wave, has seen those increases from fiscal year 2018 to over $300 million in additional funding in grants and services research for treatment being dispersed by NIDA. $300 million worth of funding just in those last 6 years. So when we truly think about we're addressing and we're seeing that there's an issue and we're wanting to, as they say, put money towards the problem, NIDA and the federal services and research systems have certainly done that by increasing the number of grants and services research by SAMHSA that's going out in that same time. But unfortunately, while monies and services have increased, sadly, so have overdoses. This first graph shows that same, you saw the overdose through those first waves 1, 2, and 3. This has showed the trend of consistently increasing overdose deaths from 1999 up through, as they say, about 2015, when we say that third wave started. And then look at the numbers exponentially increase from 52,000 deaths in 2015 to just released last Wednesday for 2022, there were 111,543 deaths. So that's certainly doubled just in those last 7 years. Additionally, look at the numbers for Cook County. If we say at 2015, we were only at 500 deaths. And the recent, as Deborah mentioned in August, reported was 2,000 deaths to opioid overdoses. And of that, just over 90% of those had fentanyl in the toxicologies of those persons who had overdosed. So we see that despite the monies that are being spent, the services that are attempting to be created, we're still seeing overdose deaths increase at a sad and exponential number. The correlations that Spencer recently put forth and some of his colleagues to say what might be the reasons for the recent upticks in these overdose deaths. We know that from that wave 1, when there was prescription medications, to that second wave, the decrease in prescription pain medications in the drug supply, unfortunately, did not happen concurrently with an increase in treatment resources. So all of a sudden, pill mills stopped, the number of prescription pills in the circulation decreased, but those patients were already dependent. They already had an opioid use disorder, and services didn't immediately or sadly even precedingly follow that push down of the prescription pills that were available. So what did patients do? They moved into the utilization of the illicit supply of heroin that was currently on the market. So prescription pain users started that, and then the heroin supply, because at that time the demand, if you recall, we were still in Afghanistan and attempting to monitor how heroin was moving across into the U.S. The heroin supply had to find ways to augment for additional heroin just to keep up with the demand of patients moving from the prescription pain medications to the current illicit supply that was available on the market. That's why the rise of synthetics to keep up. And then fentanyl became that consistent synthetic additive in the drug supply. So prior stable users who knew, okay, if I take about this much heroin, I can manage that, I won't overdose, they were no longer able to navigate their quote unquote safe use with a fentanyl overdose death being only at potentially 2 grams or less than that. That was part of our initial notice of those increased overdose deaths. Persons that had used heroin for 10 or 15 years, but no longer could manage with the additional fentanyl in the supply. Co-occurring drug use also increased during this time, so that now in toxicology, there was 3 to 5 drugs in the average toxicology screen and autopsy of someone who had overdose. So, and most of those were either combinations of synthetics or other types of sedatives. So benzodiazepines, stimulants, which has now had a new rise as well, but mostly other sedatives that were part of the drug supply, then sadly led to the respiratory arrest that led to an overdose. We also saw an increased number of overdoses across all drug use. So those who may have been at a party and recreationally tried ecstasy or a stimulant, it was now tainted with fentanyl because unfortunately, drug suppliers and drug makers don't have quality control, so they're not wiping down and cleaning off what they're doing from one drug that they're utilizing to the next. So contamination certainly becomes apparent. And a student who may have bought Adderall from a friend to study for a test, unfortunately, if it was tainted from fentanyl, we had these first use overdose deaths that actually increased from the first time someone may have taken a pill illicitly and it had been laced or tainted with fentanyl. We also saw an increase during this time of overdose deaths from the underserved urban settings, which had initially laid part of that first wave of the overdose crisis, to now urban settings. So the typical overdose death victim changed from rural white West Virginia or the Appalachians to urban Blacks during that same time of 2015 to 2018. And then misperceptions in substance use care, treatment, and healthcare with patients related to substance use treatment, because at that time in urban settings, methadone was the prominent medication available, if it was available for those persons, also led to issues. And then sadly, lastly, when we pull back the curtain, racism and discrimination in substance use healthcare also is a large contributing factor in what we're seeing now as the growing rates of overdose deaths, and sadly now the trend of overdose deaths occurring predominantly in Black and Indigenous persons of color populations. You know, there was a traditional statement that there was racial disparities, and that traditional racial disparity was a fairly common ground, particularly in communities of color where there might be the urban legends or myths that happen in rural or urban settings from healthcare, where whites were assumed to be less likely to get arrested for substance use and more likely to get treated for opioid use disorder, and Blacks and Latinos were more likely to get arrested for substance use and certainly less likely to be offered treatment or services, which was part of the age-old thought pattern of the day. And so when we take a look at those changing patterns that we discussed, we saw in that same third wave from 2015, the red line that had been fairly consistent in the 2000s of Black deaths from overdose suddenly skyrocket. The blue line of white persons who overdosed consistently growing during that prescription drug wave, and then now either jumping and dropping, but certainly not increasing as the level of the red line for Blacks or the dotted green line, which is Indigenous population. We see during that same time the Latino line, which had generally been less and lower than either of those, because generally Latinos' substances of choice were more likely alcohol than illicit substances. We now see that rise on the same trajectory and pattern of increase during that same period around 2018. But during that 2015 to 2018 period, Blacks actually overtook whites for overdose deaths from year to year from opioid use. But where do we get to this point where pulling back the curtain reveals racial issues related to stigma, shame, and substance use services? It's one of a point of pride in being an employee of Rush that it was actually Benjamin Rush, the first psychiatrist, who documented the need for services for alcohol use disorder and at that time morphine use. So this isn't a new issue. And at that time, diagnosed alcohol use disorder and opioid use disorder or morphine use disorder as a medical problem needing medical treatment. But why did we have those diagnoses for those two drugs, particularly during that time? Next slide. Take a look. Next. Take a look at the use of substances in society pre-1910s. This is your typical counter of the Walgreens that was first starting out around that time. There'd be cocaine toothache drops, Ms. Winslow's soothing syrup, which the soother was morphine, Coca-Cola, which was a lovely tincture with cocaine, and my personal favorite, the one-night cough syrup that contains alcohol, cannabis, chloroform, and morphine. So I'm not really sure if the next day they even remembered that one night, but certainly that cough was gone. after those substances. But these were all available over the counter. And so what changed during that time? The pictures on the right, sadly, are problematic, but they're sadly the media portrayals of Irish coming into the US and using alcohol recreationally, Asians paving our railroads in the West using opium or morphine recreationally, and freed African Americans who, as it was thought, if they were able to get a hold of alcohol or any illicit drug, would immediately be enraptured by white women. And so the preservation for white womanhood was needed. So in 1914, the Harrison Narcotics Tax Act said no more OTC, over-the-counter narcotics. All of those labels from the last slide had to go away. Medications were much more controlled. It actually limited what doctors could actually prescribe for people who were using opioids at that time. And then after that Harrison Tax Act, the Supreme Court issued a number of court cases criminalizing rather than treating substance use for people who use drugs. And in addition to that, during that same time, 25,000 physicians who were prescribing morphine for patients with morphine use disorder, or what we would call now opioid use disorder, were indicted. Yes, sent to jail for those Harrison Act violations. And so at that time, all morphine maintenance clinics, because that's what they were called basically at that time, were closed. So the medical treatment for opioid use disorder disappeared. And what was left in its place? Sadly, a stigmatization and a criminalization based sadly on immigration issues and racism after that. And the narratives show. What did we see in the papers if we looked in the papers? That marijuana would cause weird orgies, wild parties, unleashed passions. Oh my, so many negative things. And in related to who? Is the Mexican nation locoed by a peculiar wacky weed? Drinking leads to neglect of duty, moral degradation, and crime. And then one of the highest well-known African Americans of that day, Jack Johnson, a famous boxer. Well, of course, he's drinking and he's using drugs, so he must want a white woman. And all of those media narratives led to public outcry, the prevailing racism and gendered issues of the day. And so that addiction was no longer the domain of medicine or public health. It was a criminal justice problem. And those people needed to be in jail. Addiction was a moral failure or a lack of willpower. Heroin addicts spring from sin and crime, and the church, unfortunately, was happy to go along with that because those same types of supremacist attitudes were right there along with the church. And so treatment became a vacuum. It was only until the 50s that the mutual aid societies began with AA. Otherwise, persons who had opioid use disorder were negated to narcotic farms, ECT, psychosurgery, other types of sterilization, because of course eugenics was also popular, framing that same narrative of racial issues. And so those persons certainly couldn't procreate. And medication, if and when it was given, was only given in detox. And so as we started to make changes in the 60s, and the 60s is an area of great change, not only of socially, but also scientifically, we started to try to say, hey, what do we need to do and how do we need to address these issues? Sadly, the return to science was limited related to race. This quote on the left is actually by one of the leaders in our US government. We knew that we couldn't make it illegal to either be against the war or to be Black. But by getting the public to associate hippies with marijuana and Blacks with heroin, and then criminalizing both heavily, we can disrupt those communities. We can arrest their leaders, raid their homes, break up their meetings, vilify them night and day on the evening news. Did we know that we were lying about the drugs? Well, of course we did. That's John Ehrlichman, the assistant to President Richard Nixon. And so when they passed the act in 1974 to open up methadone clinics, they truly only opened them up in Black communities. And we see and saw the stigma and the shame of being up at 5 a.m. waiting in a line to get methadone. And we saw that lasts even to the day, because look at the map below that. That shows where the methadone clinics currently are in the US. And you'll see that they're basically sadly relegated to urban settings, some along Appalachia, and those were mostly a result of the recent opioid overdose crisis, and along the Navajo Nation and Native American lands. And so those changes continue and exist. The other was related to criminal justice and actually time served for substance use. Because remember, substance use is bad, the people are bad, so we're criminalizing it. On the left is the actual, what we feel, the use of who's using substances. So although Blacks are actually using substances slightly less than whites, most groups, white, Latino, Black, and others, about 15 to 20% may have a substance use issue. And around that same time, who's selling substances is right equal about Blacks and whites. But look who's going to jail for it. For drug-related arrests, over twice as many Blacks than whites. For state-related sentencing, 3 times Blacks than whites. Federal-related sentencing for drug use, 4 times Blacks than whites. So who's using drugs versus who's being policed for it, very different issue. And also, what method are you using a drug? Now, we as healthcare providers know that cocaine is cocaine is cocaine, but unfortunately in 1986, knowing who was using what types of cocaine, the Anti-Drug Abuse Act set the minimum sentence for cocaine use or possession as crack cocaine, 1 teaspoon, 1 1/4 teaspoons of crack cocaine, you would serve the time as if the same time as if you had 2.5 cups of powder cocaine. Well, wait, isn't cocaine cocaine? And it was only until 2010 that the federal ratio was actually decreased from 18 to 1, not 1 to 1, because remember in 2010 that was President Obama, and if he had changed that from 1 to 1, what would everybody have said? Because unfortunately, if you recall, what was one of the major issues that those contrary had regarding President Obama was that he was Black. So we couldn't make it quite 1 to 1 yet. But at that point, then a 1/2 cup of cocaine, then you'd serve the same time as if you only had a teaspoon worth of crack cocaine. And so the methods actually even became differential, and they were certainly differentially skewed toward race. And so when we saw the movement of this recent overdose epidemic, and if you see that first map of the US is in 1999, and you see the 2 small red dots of West Virginia, and interestingly, the red dot of the Four Corners area in native lands and indigenous reservation area. And you see that continue to proliferate across those years to 2020 to 2004, where it's still now moving through Appalachia and sadly just slowly continuing to envelop the Native American Southwest. You then see the proliferation of the opioid crisis from just those 2 points to now plaguing the entire country. And so the initial deaths that were more specifically rural whites progressed nationally. And sadly, the media and narrative portrayal, and we know that media carries the narrative, carries the public's perception of these issues, actually went to moving from the crack cocaine, quote unquote, crackhead negative narrative to a more humanizing way. So it led to an acceptance of potential for treatment instead of incarceration. And I use that picture, oops, one more, just a second, Deborah. And I use that picture of Dave Chappelle, not just for the comic relief of having to take a break from going through these statistics, but also to help you to recognize that those same people who may be negatively affected by these stigmas internalize those stigmas. So when people of color see these negative narratives, sadly, of people who look like them related to substance use, they internalize it too. And so that develops an additional level, not only of shame, stigma, but of a separation of those groups for those persons who may use those substances. And sadly, an internal ongoing trauma related to the experience of those of BIPOC groups in the US related to substance use. Go ahead. And we see that across all services now. This actually shows from SAMHSA the level of who's getting services and treatment for mental health or a substance use disorder. Right now, approximately 90% of African Americans are getting no treatment for their substance use. Only 67% for mental health issues. So that's slightly less stigmatized and a little bit more access to care. But sadly, there's still minimal access to care. And these issues continue to show that substance use disorders are the least likely to receive any type of treatments. Go ahead. The minoritized treatment even goes to them after an overdose. This study shows privately insured patients who suffered from an overdose and were treated in the emergency room. Now, of course, the referral rates for services were low, less than 20% across all groups, but particularly minorities and most notably Blacks were half as likely to be provided with any type of treatment for or medication assisted treatment than whites were. And so it wasn't about insurance because these were privately insured patients. And so if there was a heroin overdose, they were half as likely to get any type of offering of medication assisted treatment. For prescription overdose, even less, 70% likely to be offered treatment. This unfortunately patterns all as well for Medicare patients and for pregnant patients with Medicare and private insurance. So it's across all groups. I sadly won't continue to inflict the pain of seeing additional stats showing this. And then even if someone was prescribed buprenorphine, the disparities continued. The number of days that someone was prescribed a medication such as buprenorphine to help with cravings, decrease withdrawal, and decrease the risk of overdose is twice as high than those that were Black being prescribed and staying on and being prescribed a medication for up to, as we said, that 50 days. So on the left-hand side, the number of days that someone was prescribed was about 55, much less, the number of days less than 40 days for Blacks. And then when we looked at after 6 months, and we know that 6 months is a cardinal sign, if we can keep someone alive for the first 6 months when they're on buprenorphine, then we're more likely to get that 60% and 50% after 5 years that we showed earlier. But only 27% of whites had been continued to be prescribed buprenorphine for 6 months, but less than 20% of Blacks. So even if you were able to luck out and get prescribed buprenorphine, the days that you were given buprenorphine as part of your treatment were notably less. And so not only was it an urban myth, but sadly it's an actuality that whites are less likely to get arrested and more likely to get treatment. And Blacks, even still, once substances are legalized, like here in Illinois, legalization of cannabis still shows higher arrest rates for Blacks than whites, and still less likely, unfortunately, to get treatment for opioid use disorder. And in the news just this past weeks, and these are just the more recent notes, there's still some progress, but sadly lots of pushback. In 2022, so just last year, the Biden administration reversed the Justice Department position on overdose prevention sites, and we'll talk about that a little bit more later, and also developed the first grants for harm reduction for $30 million. And of course, they said that we would provide safe smoking kits and other safe use kits because that actually decreases the likelihood of overdose. And immediately in the news, those who were contrary to this service reported that the Biden administration is giving people crack pipes. What's that media picture that Tanya just showed me about who's using crack, who's getting those services? And sadly, it falls into the narrative of who's getting government help versus those who are pulling themselves up by their own bootstraps. So sadly, the progress that could potentially have happened was immediately stopped. They removed that caveat, that feeling for that write-up for safe smoking kits from the grant because of the media pushback of giving out crack pipes and who crack pipes was a code word for Black people. In February 2023, the X waiver was eliminated so that prescribing buprenorphine wasn't some type of super secret club that you had to take lots of training for to be able to do, because you could prescribe buprenorphine for pain, for cancer pain, for other pain issues every day, but to prescribe it for substance use, you had to jump over an extra hurdle. And sadly, it was just in February that finally the crack and powder cocaine sentencing was set to parity. We recently expanded the definitions for harm reduction and what harm reduction services could be. But just last week, Philadelphia's city council voted to ban overdose prevention sites in its city. And we're seeing in this last legislative session the try to pushback of now saying if someone has fentanyl, then we can put them in jail longer. But the person who's using a drug doesn't know what's in their drug. And once again, we're recriminalizing the use of a substance. All of this skepticism, all of this sadly real life evidence has really eroded the provider-patient relationship, particularly since COVID-19. Because true enough, we see you. We see what's happening. We see that some are getting care and some are sadly being consigned to die. And so we see that when physicians treat Black and Latino patients differently, and we know it, then how do we trust when you do offer care, when you do offer services, when you're actually trying to overcome these barriers? And now we really need to pull back the curtain and develop what we can do to go forward. Because how do we change these narratives about media, drug use, and treatment when sadly we've been doing the same thing over and over and expecting different results? And if you know anything about substance use services, AA calls that the definition of insanity. And we can't be insane because people are dying while we're trying to do the same things, and that's why nothing is making a difference. So what do we need to do? We need to redefine prevention, make a definition, and continue to improve it and enhance it for harm reduction. We need to redefine what treatment needs and recovery so that we can actually address all of these areas to help people to not only be able to stay alive, to get into treatment, to get good treatment, and to be able to have those 60 and 60% outcome rates that we talked about earlier. So part of that is prevention. We can't just say no or dare people when the prime age for substance use is that 10 to 20, that little red dot that you see there combining for 10 to 20. Yes, 10 to 20 is when we need to get to people. And these are people who are now enveloped by the TikTok challenge, which means what's happening on there? People may be using substances as a TikTok challenge. We now need to teach resilience. We need to look at programs that actually address the reality that substances are out there and how to make better decisions and choices in staying safe, which is a safety first program. We need to address issues with harm reduction. There's still many states that don't allow syringe exchange. The states in light gray don't. And so those persons are not only consigned to the likelihood of HIV or Hep C, but when there's no longer a syringe service program, which is thought of as the initiation of trust in harm reduction, where are the services to get people into treatment? And CDPH and other services, we're really looking at how we can make a difference to keep people alive so that we can reach out to them, reestablish that trust, and get them into treatment. The SAMHSA recently released the expanded guidelines that include working on our language. We have to change the way we talk about people who use drugs. They're not addicts, they're not junkies. We wouldn't call someone who is diabetic and who uses insulin, oh, you're addicted to insulin? No. So we actually need to refrain from that and use different language. Legalize syringe services, paraphernalia, and safe use supplies. Work on liberating methadone for those OTP clinics if you notice that we're only very scattered in urban settings. Have additional safer use strategies like neverusealone.com, who'll sit with you on the phone while you use. So if you don't respond or become unconscious, they can contact someone for help. Increasing and expanding naloxone, although the over-the-counter naloxone is currently costing about $45, which is still problematic. So we need to make sure that that's widely available. And Medicaid coverage for incarcerated individuals, because the 30-day overdose rate for those released from jail is over 30% risk of overdosing and sadly dying. So if we can start them in services while they're incarcerated, that decreases the likelihood of their overdose afterward. And we do need to talk about overdose prevention sites because it needs to enter the chat. Overdose prevention sites are saving lives in over 20 countries around the world, 200 sites for the last 30 years with notable research. They're just not available here in the US. OPS sites are fundamentally different from sobering centers because they're based on a peer model with people who are trusted versus the medical community. And we admit that we need to work on our trust with our patients. And it's not a medical stabilization, it actually moves you to recovery because there's housing services, social services that are there at an OPS site. And just in 1 year, On Point, New York, who opened their overdose prevention sites in 2021, reversed over 1,000 overdoses. That's half of what Chicago's deaths were last year. If a location like that could be here in Chicago, we could work towards halving the overdose death population in just 1 year. Because we know that respiratory arrest leads to brain death in less than 10 minutes. So immediate reversal is needed, not someone trying to drive someone to a sobering center or drive them to an emergency room or sadly wait for EMS to arrive. So someone being able to immediately intervene with an overdose leads to the best outcomes, and with the additional services, social support, housing for help. And then treatment needs to meet people where they are. And it's not necessarily segregating treatment so that only white folks go to this treatment or blacks to this treatment, but actually having black people at the table, helping to develop what programs are there, what works for their communities, you talking to their communities and what works for them. And these are a number of the programs that are currently available that are trying to alter how treatment actually happens and where it occurs. So acknowledging that the disparities exist, even telling your patients, hey, I know that some folks are getting help and some folks aren't. I'm working to change that. Tell me what your experience is. You will then begin to rebuild that trust. Learn how to use expert in motivational interviewing. Motivational interviewing works really well for obesity, for hypertension, for cholesterol, for all chronic issues. Train in health equity, just like this lecture, so that you can remove those barriers to care. Because it's not just about language, it's recognizing that some cultures prefer their family being involved, how you're notating issues in the records, and whether walk-in or telemed services or other services to help with being able to navigate through a healthcare site are available. Work to diversify your staff and learn MOUD and prescribe buprenorphine. If you're prescribing insulin, that same person you can prescribe buprenorphine to. There's no hill to climb anymore. There's no secret special club anymore. And if you already have a good relationship with your patient, you're already ahead of the game. And then no one gets denied. If they're having a use problem, prescribe the buprenorphine to be able to help. Even my dog agrees. And then expand emergency department MOUD services. Most patients who overdose have been to the emergency department 4 to 6 times before that final fatal overdose. If we can start Suboxone there, they're actually at a 60% rate of continuing on Suboxone after 1 month. That's a great way to be able to provide those services. And the MAR Now number is available because you can actually connect your patient to services and care just by a phone number and using that in your practice. And so looking around your office, does the office have pictures of everybody that comes into my office? Or are the people in those pictures pretty monochromal? Are my staff looking like all the patients that come into my office? All of those things help to move toward that safe space for your patients and culturally adapting to what needs to happen to help re-engage that trust. And then working for recovery, creating those safe spaces, just as we just talked about. These are some of the programs that are currently being funded, many by those federal dollars that we talked about, to make a difference in how people feel comfortable continuing in those recovery spaces. Persons of color should be at the table. This is a statement of the harm reduction community. Nothing should be about us without us involved. Involving your patients in how these decisions are made would be a great way to encourage and rebuild that trust. And persons of color may have unique needs that may be related to trauma, generational issues, community support, or the ongoing microaggressions they experience that make specific recovery services for their groups very appropriately serviced. And we should be funding and continuing to make sure that that funding is directed to those groups because sadly, Blacks and Indigenous groups remain at the highest risk for overdose. And then research. These are the current NIH programs really focusing on the needs of Hispanic, Latino, or African Americans in substance use services, utilizing community-based participatory research, which asks the community and has the community at the lead of developing the activities, the research, what's needed, what are the problems that you see, how can we help, versus we're Rush and we're here to help. No, we need to ask the community. We're Rush and we want to hear what you have to say. We want to hear what you think we need to do and how can we better work to build your trust and improve the outcomes in your care. So what did these kind of services look like in Benjamin Rush's time? He actually developed and researched sober houses for those with alcohol use disorder and morphine maintenance, and actually did research. The research that led Freud to cocaine was actually research in what are the things we could do to help persons with alcohol and opioid use disorder. And treatment at that time was based on that medical model, despite the race and sexism issues that were part of the society at that time. Here's what we're doing now at Rush. Oh, those same services, working and training police and first responders so that they know how to approach patients who use drugs more appropriately, how to route and resource rather and divert rather than incarcerate, training and actually advocating and going where people at. We're at a laundromat on the left there and handing out Narcan, educating the public in substance use services. Our first NIH grant that I'm the uh, program investigator for and bringing in better together so that we're bringing help closer to home for Black patients with substance use and advocating for services and change here with Mayor Brandon Johnson just a couple of weeks ago and developing toolkits for providers. So what can you do? Educate yourself, your colleagues, and others. We need to do things differently because just doing the same thing we know is insane. We're not doing that. Taking our courses, taking trainings for prescribers, providers, utilizing the Illinois Helpline toolkits with Rush developed on the Illinois Helpline side to help to learn how to prescribe medications for opioid use disorder. Working toward best practice, taking courses on health equity in medicine, and actually evaluating your practices. Look at your handouts that you're giving out. What do the people look like on that? What is the language on that? And are we accidentally playing into stigma and shaming narratives? Are we prescribing to everyone who needs those prescriptions and treatment? Does our EHR reflect potential issues in equity so that if a patient no-shows a couple of times, all of a sudden when we click on their name, which happens in Epic, it'll say this person no-shows, you should double book. And we accidentally implant an implicit bias into a provider about what that patient's level of engagement might be without any knowledge of what's really going on with them. And looking at your workflows to address those health equity issues. And then volunteer because your voice lends credibility to what's happening out here. Talking to your medical societies, insurers, working and volunteering to be on the opioid settlement funds program so that we know that the services and funding is going to where it needs to be. Working for public health on a city, state, or national level, and then pushing back against, sadly, what we're seeing in these current anti-equity narratives so that no longer we can use the DEI word, it's a bad word, or CRT, or that we're anti-woke when we're not even sure what woke is. All of that, sadly, is pushing against being able to provide equitable care to your patients. And regaining that trust is fighting against those negative narratives. And if you need help being able to do it, contact us. We have an MOUD class that's available right now to get you started in prescribing. We actually do ECHO trainings, which is a shorter term training for a couple of months where we really help to guide you through it. And we realize your time is important, so we compensate you for it. because we know that the outcomes will improve not only for you, but your patients. And who doesn't want to be able to say that we've got a 60% efficacy for a medical illness that you're treating? Any questions that you have? These are some of our other pictures out in the community. As we say in our motto, saving lives. That's what we do. And thank you for your time.
Thank you, Dr. Sorrell. This was an excellent presentation. You so clearly articulated the challenges with helping people with opioid use disorder and other substance use disorders, particularly around health equity. Um, and you provided some very clear, tangible tools that we can all use to address this problem. So thank you very much. Um, I know we don't have any questions in the chat. And Deborah, I know you wanted to make a few announcements before we end. Do we have time for a couple questions, or should we just go to the announcements?
Oh, we can have a few questions on there, on it as
Okay.
well. So,
What one question I want to ask Dr. Sorrell is, I was struck by your comment that despite the increase in funding nationwide, overdoses have been going up. And what do you think we're doing wrong as a country? We're spending a lot of money, but we're not making a dent.
Well, as we pointed out, and wasn't just me, but actually research have been studying what are we doing wrong. Part of it is that one, we're not providing the necessary treatment and access to care and services for removing that cycle and helping people get out of that cycle of substance use. Because sadly, what's happening is they're using, they may be trying to get help, they're reaching out for help. There's a waiting list for programs or inpatient services. There might be a waiting list for a prescriber. If I live out in Rock Island, is there a buprenorphine prescriber? And then they use again, and we're losing them. So that's why we need two things. We need the increasing number of treatments and the types of treatments, and we need to have methods to keep people alive while they're using so that we can reach out to them. Because sadly, when someone goes to an emergency room, a medical encounter, and they have on their chart that they use a substance, that encounter changes. And we know that it does, sadly. So working with providers to change how they interact with patients who use drugs has to be a start too, so that we can work toward what can we do to help engage people and keep them alive until we can get them involved and connected to treatment.
Yes. Well, thank you. One question did come in. Uh, are there studies connecting use with adverse or poor pregnancy outcomes?
Well, certainly if someone is using a substance in an active substance use pattern, they can have adverse outcomes, but it's actually more related to those structural and social determinants of health. If they're using, are they following up with their prenatal visits? Do they have adequate housing and social support? Might they be at risk of either being arrested or utilizing crime as a method of obtaining their substance? So they may be at risk of either being trafficked or prostitution, which may also lead to those adverse pregnancy outcomes. What we do know is that patients who start MOUD have actually very good pregnancy outcomes with baby and with mom, because while they're in treatment and services, when they're on buprenorphine, we can help them with housing, we can help them with social support. They can become more stable so that we can work with regaining those family connections, and those all lead to more positive outcomes. It's not just the substance use itself, it's all those social issues related to substance use that make the outcomes adverse, because we don't want to unfortunately stigmatize again or shame the use of a substance. It's the areas around it, housing, legal
Right,
issues, social
right.
services, that cause the poor outcomes.
Yeah, good point. Well, I know we're at time and we have a few other questions that came in. I don't know, Deborah, do we,
go
um,
ahead. Let's do these two other questions and then we'll close,
okay,
because
all
this
right.
is too good not to do.
I agree. All right. So, Dr. Sorrell, thank you so much for this great presentation. My question is around the increase of xylazine found in the fentanyl supply. Are there additional steps that providers need to take when treating patients with opioid use disorder and are found to have xylazine in their system while seeking treatment?
That's a great question, and I always remind people that it isn't just the substance the main point of this is that we're also not truly treating mental health issues.
Mm.
There's no supply without a demand. So, and physical pain from having fallen and broken a leg, to mental pain from trauma, early childhood events, that pain feels the same. And sadly, opioids relieve that pain, because opioids don't know the difference between physical pain and emotional pain. And it's always easier to get a hold of alcohol or drugs than a psychiatrist, although you have two on this, well, two psychiatric practice providers on this call. You're lucky. Our therapy services. Xylazine right now in the Cook County area is in about 20% of the tested supply. Uh, Xylazine, actually, they're just finding out, has some opioid properties, although it's a veterinary sedative. So we still always want to utilize Narcan. We still always want to engage all those social determinants of health issues, housing, social services, social support, therapy, because once again, many people who are using because that's deadening the pain of an emotional or a physical issue.
Mm.
And also recognizing that xylazine use, whether it be IV or oral, might lead to sores or wound care issues. So we want to make sure that someone is being supported with using good skin lotion, that they don't want to have dry or excoriated skin. They want to avoid getting any type of breakouts. And that if there is any skin involvement, we want to address that fairly quickly. Rush is actually doing a xylazine wound care training on October the 3rd. So
Mm.
contact us for additional information, and we'll let you know everything that you need to know about specific wound issues with xylazine.
Excellent. Well, thank you. And our last question, and then I'll hand this over to you, Deborah. Dr. Sorrell, what efforts are coordinated with emergency response or the police?
That is a very good question. And working with EMS, we actually track, CDPH actually tracks what's called the hotspots, where the number of opioid use calls for 911 are being made. We actually work with developing our outreach and educational services and train the trainer programs for agencies and organizations that are in those hotspots, so that if you're at a church's chicken and someone may pass out in front of your store, you know how to be able to respond to keep that person alive, how to call 911, and then wait with the person. And it's really easy, with the Narcan now, it's available. What you do is you lay them down, you spray, and you stay with them until the EMS arrives. So we're also actually training not only emergency response and first response providers, but the police on the trauma that's associated with that, because trauma may unfortunately lead to some of the stigmatization. And we talked about Dave Chappelle and how we internalize when we see and are involved and experience and are exposed to a lot of traumatic issues, and seeing someone almost die or having to revive someone can be traumatizing. We
Yeah.
work with trauma informed services to help that person process that, so that they don't develop a negative stigma towards persons who might be using substances because of the prior trauma that they may have had, either in their exposure or in their lives, because the opioid overdose crisis is touching everyone. People may have a family member, a brother, a cousin, an uncle who may have been impacted, and that traumatizing experience may go out with them when they're presenting and working in society too. So we want to provide good processing and self-care, because once again, it's the mental illness behind many of these issues that are driving not only the stigma and the shame, but sadly the overdoses and the lack of access to care. And we want
Yeah,
all of those to change.
I hear you. And I'm sorry, Deborah, I just saw one more question. Should
It's
we
okay.
be
Go
a little
ahead.
okay? Are you okay, Dr. Sorrell, on time?
Sure.
Okay, all right, cool. Thank you. You mentioned the overdose concern with fentanyl was initially because users were unable to judge usage. Do you see this as a concern now with xylazine as well?
Well, xylazine is the sedative. They actually have some quantitative. Cook County, and one of our doctors that works there has really looked at what are the levels of xylazine that are being added in the supply, in that 20% that we might be finding in our testing supply. The sedation of it uh, is not mediated by Narcan. So if you give someone Narcan, it will knock the opioid off of the receptor, but there is a part of that xylazine that is still causing sedation. So they are more likely to need rescue breathing as
Mm.
part of that response,
Mhm.
because it might take their body a little bit longer until that breathing response kicks back in because of the sedation. Other than that, they're not specific issues that are related to just the xylazine content, except those potential issues for wounds. We want to encourage everyone to still give the Narcan. And with fentanyl, you might have to give that second dose. That's why they're 2 in a box. But also to know that because of that excess sedation that the xylazine has, it might take them a little longer to revive. And so they may need some rescue breathing in the interim until they may not be the 1 to 2 minutes that maybe normally happens with Narcan.
Well, thank you for that information.
Sure.
Well, thanks again, Dr. Sorrell. This is wonderful. We appreciate all of your insights and information. And I'll pass this over to you, Deborah, to close this out.
Thank you,
Thank you,
guys.
Thank you, Dr. Allen, and thank you, Dr. Sorrell, as well, for a very informative presentation overall. And this PowerPoint will be made available to the attendees, so please feel free to contact us if you'd like a copy of it. The video will be on the website in about a week. It'll be on our IOMC's YouTube channel as well, so you'll be able to access this at 24/7 once that goes up. So I just want to remind you that there's a program tomorrow at Rosalind Franklin University. So consider attending that or joining that. You can get access to the registration off of the IOMC website itself. And then in November, on November 28th, join us with Dr. Georges Benjamin on public health and what the future is there. And then most importantly, to close out 2023, attend the State of Health of Chicago. Registration will open very soon, in about 2 weeks, for that program. And we'd like to see all of you there and invite your friends. So feel free to share ideas with us by sending us an email to infostaff@iomc.com .org if there's something that a topic that you want us to cover or something that's of interest to us as well. Also, you can check out the LinkedIn page and blog on the website to stay in touch with us. So finally, thank you, both of you doctors, for your time and attention today in putting this together. Very robust presentation with a lot of detail, a lot of data, and very helpful overall of how to move forward. So have a good day, everyone, and have a good week. Look forward to seeing you again. Bye.
You too. Bye.